Children can have respiratory allergies, food allergies, or contact allergies. Using adenoids and adenoiditis as examples, we began to discuss allergic rhinitis. I think we should continue. Allergic rhinitis is a very interesting topic. Disease is becoming more and more common nowadays. It is diagnosed very frequently. Differential diagnosis is often performed, or it occurs in combination with other conditions. They make a diagnosis and find allergic rhinitis, so it's important to understand this clearly and correctly. We are dealing with, but in this case it is still allergic rhinitis, and what is primary, what is secondary. What predominates in allergic rhinitis is nasal congestion, and sometimes rhinorrhea can also be included here. It can be either partial or, depending on the season, can be year-round. Nasal discharge is a key symptom. It occurs frequently, and everything depends. More often, it is abundant. Still, with adenoiditis, the discharge is not as abundant, and its nature is more mucopurulent. Itching in the nose, burning sensation, itching. The child is constantly trying to rub their nose. Sometimes the nose takes on a certain look. There's a reddish tint here, where you can see that the child is constantly doing something there, sneezing. It's very important here to note the nature of the sneezing. Sneezing can occur in the mornings or during the day. There can even be coughing. All other aspects associated with allergic rhinitis are manifestations of general allergy. This is again tearing of the eyes. It could be a cough that is related to irritation of the upper respiratory tract, which is again the same pharyngitis. How is the diagnosis made? The diagnosis is made during an examination, and naturally the diagnosis is also made when tests are ordered. The first thing is you go to a pediatrician. If we're talking about children, you go to a pediatrician. If he sees impairment of nasal breathing, lack of free nasal breathing, constant sneezing and coughing, the first thing to do is to differentiate it from a viral infection, a viral agent or a bacterial viral agent, Donadit and Vin. And for allergic rhinitis, we order a complete blood count, and in the complete blood count, we determine whether it is allergic, whether it is a viral agent, or if it is still closer to allergic rhinitis, where an ENT doctor will be involved in determining immunoglobulin. And or we often see and hear the abbreviation immunoglobulin E. It's possible, but with some reservations. Total immunoglobulin E and specific allergy diagnostics may be possible during a follow-up visit to the ENT doctor, or as prescribed by a pediatrician. The ENT doctor takes swabs from the nasopharynx, from the nose, takes the swabs and examines whether they are looks at the cytology, that is, what kinds of cells are present, whether leukocytes predominate, whether eosinophils predominate, depending on which cells are present, a diagnosis can be made. In cases of prolonged course or complications of rhinosinusitis, naturally, X-ray examinations are used for monitoring and for making a diagnosis, whether it is already rhinosinusitis or perhaps allergic rhinitis with such a course, with a prolonged severe course or with its complications. What is used in treatment? In the treatment of allergic rhinitis, of course, topical glucocorticosteroids are still. One of them, as everyone knows, is mometazone or Nasonex. The brand name of the medication is. Next, this is a medication that is used locally in the nose, and the therapy is long-term. Yes, well, the total amount. Usually this is considered for the further course of the disease, or already the doctor uses it very often. Now we have started using anti-leukotriene drugs, such as montelukast. Very often now we see them prescribed. This is already included in our protocols, along with antihistamine medications. Second and third generation as well. They are used during exacerbations of this rhinitis, perhaps most often. Loratadine is still prescribed. It is possible to prescribe local symptomatic use of decongestants, still local medications, vasoconstrictor drugs. But according to the latest data, it is not recommended to use them for more than 3-5 days. Membrane stabilizers can be used, such as chromoglycic acid, but nowadays they are not always available on the market. It's hard to say why these medications were used. They were included in prescriptions.